Hi everyone, this is Neel Raithatha, consultant audiologist and director of Clearwax. Thank you for joining me in my latest video using the iClearscope endoscope, and it's of a really interesting case of a patient who attended with a blocked left ear, and I'm just working at the entrance here. So they have got a combination of matted earwax, a lot of dead skin, and as we approach the eardrum it really does narrow and it's quite bendy medially, and they've also got a lot of wax directly impacted and occluding against the eardrum, which is quite difficult to remove, so do stay tuned for the whole procedure. And I'm starting off by removing this plug of wax, which is enveloped in some dead skin. It's just got trapped at the entrance. I'm just going to wriggle this out. And as I pull this away, this patient has a lot of dead skin here, and it's coming away in ribbons, long sheets of skin. So that's just hanging out of the patient's ear. It's almost like that musician's trick when they've got a handkerchief up their sleeve, and as you start pulling it, it's never ending. And just to the left there, that's the second bend, and so from beyond that point the ear canal veers off to the left. So I've got quite a bendy ear canal, and again we've got another tail of skin at the roof of the ear canal. I've just reverted to the fine end because we're getting a bit of clarinetting. When you suction dead skin like this, there's always a risk of creating what we call clarinetting, and that's when the skin violently flaps at the tip of the suction tip and it emits a very loud squeal. It's loud for the patient but also for myself, and by reverting to the fine end you somewhat mitigate that clarinetting. It reduces the effects of it, and you can see this skin, it's all around the periphery. I'm just trying to peel it away, and once we peel the skin away you'll see some really impacted wax. But the slight issue with the fine end is that it's far less powerful. The normal Zollner suction probe, depending upon which gauge scale you're using, if it's a French gauge then it is around a 6 French gauge, and the way you calculate the diameter in millimeters is with the French gauge you divide it by 3, so it's around 2 millimeters. If you're using the Birmingham gauge scale, which is more common in the UK, would call this a 14 gauge or gauge. The people pronounce it differently. And so the standard Zollner suction probe is roughly 2 millimeters outer diameter and then about 1.6 or 1.7 inner diameter, depending upon the wall thickness of the suction tip. You can get different types. And then the fine end is an 18 gauge suction tip, so that's around 1.28 millimeters outer diameter, and the inner diameter is about 0.83, I think, thereabouts. So it's almost half the internal diameter, which means it, although the suction power is somewhat greater because there's a smaller surface area, therefore that creates more pressure, but in terms of removing bigger, larger lumps of wax, you would rather have a larger surface area so it grips onto the wax much better. So this is probably about 0.5 centimetre away from the patient's eardrum. You can see how the ear canal narrows. They've got a valley here, and that's the isthmus. That's a narrowing deep in the ear, and then beyond that we've got this impacted wax right on the eardrum, and it is somewhat matted. And once we remove this, which was a bit of a challenge, they do have an attic retraction, so the top part of the eardrum is buckled inwards due to negative middle ear pressure. The air pressure in the middle ear is below that of the air pressure in the ear canal, so therefore it creates somewhat of a vacuum effect in the middle ear chamber, which is the cavity behind the eardrum, and it pulls in the eardrum. And it normally pulls in the attic region, the top part of the eardrum, or the posterior superior quadrant of the pars tensa. So the pars tensa is the main body of the eardrum, and in the case of the left ear we're probably talking about northeast, that region. It pulls the eardrum inwards there, and that's because the top part of the eardrum, the attic, and the posterior superior aspect of the pars tensa, the middle layer of the eardrum, the fibrous stratum layer, the fibrous tissue is arranged in a less organized and dense way compared to the rest of the eardrum, which makes that part of the eardrum more elastic. There's a misconception that people often believe that the top part of the eardrum is thinner. It's not. It's actually thicker, but it's just the fibrous layer, the middle layer, is less. The fibrous tissue, connective tissue, is less arranged and organised in comparison to the main body of the eardrum, which makes it just more elastic and susceptible to being retracted. And they've got the early stages of what we call an autoatticotomy. So near the eardrum, the bone at the roof of the ear canal is called the scutum, and when the eardrum gets sucked in, it can cause bony resorption. So it initiates osteoclasts, which are specialized bone cells that live on the surface, and they start to break down the bone into its minerals and tissues and redistributes that via the bloodstream to other parts of the body where new bone can be formed. So when the eardrum is sucked in, it can cause that, and it can also cause erosion just by the pressure. So you'll see some of the scutum, the bone, is starting to erode, which then means you can see more of the hammer bone. Now, normally when we visualize the hammer bone through a normal eardrum, an ear canal, you see the center part of the hammer bone called the umbo, which is attached to the middle of the eardrum. Then you've got the main body, the main stalk of the hammer bone, known as the manubrium, or the handle of the malleus. Then at the top of the hammer bone, you've got this spherical, almost like an elbow joint, and we call that the lateral process or the short process. And then you can see some of the neck of the malleus, which enters into the middle ear cavities. It's not always fully visible, and connected to the end of the neck is the head of the malleus, and that articulates with the body of the incus, which is the second of the three middle ear bones. And when you've got an erosion at the top part of the eardrum, you can start visualizing more of the neck of the hammer bone, and sometimes even the body of the incus. So you can see there's very little space to work in. I'm using the fine end suction probe, but it looks like a normal zonal suction probe given how narrow the ear canal is. So it's almost like an optical illusion. Because the ear canal is narrow, it makes the suction probe look bigger. But this is the fine end. So I put some olive oil spray into the ear. So we've managed to remove that. And you can see the top part of the eardrum. There is quite a deep aortic retraction, but there's no embedded keratin there. I'm just going to visualize it again. So you can just see how elongated this patient's eardrum is. It is really, really... so all of our ear canals, the height is greater than the width, but I would say in this patient it's significantly more so. So I'm just mopping up near the entrance a little bit, trying to get some of that drops out. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.